of oral ulcers, genital ulcers, IV drug abuse, high risk behavior. No history of camping, tracking in forest.
What is the relevance of pain in abdomen? So, Vikrant, please, you have to be quick in your reaction. What's the mic?
Some 4-5 years can present with acute abdominal pain.
Yes, 4-5 years can also present with episode of psychosis, pain in abdomen, and can also present like acute neuropathy and cause paralysis like this. So that and camping and for tracking the spelling error. It's what?
Tick-borne
Trekking. I'm sure you meant trekking.
Yes, sir.
Okay. Tick-borne. Any resident from community medicine, please? Anyone? Yeah. So what are the diseases that we get to see because of tick-borne infestations in India?
Sir, epidemic typhus. And
have you seen or read about rickettsial infections and borrelia? What is the tick for Lyme disease?
Spotted fever, rocket mountain spotted fever.
Anyone else? Okay, I'll ask you that question. Because there is suspicion of Lyme disease in this patient, because of the bifacial weakness and polyarticular neuropathy and acute condition. Is Lyme common in India?
No, sir.
It's not common. It's common where? It's common in the United States, in Europe.
North America, sir.
Yeah, North America. Okay, please. So not common in India, but however, because it is, it's kind of a very glaring thing that a patient has polyarticular neuropathy and bifacial weakness. Other than GBS, Lyme disease is a very important differential. So that's probably why Parvinder has asked this question. Okay, carry on. Next.
In the past, there is no history of similar illness and no history of tuberculosis or recurrent ear infections. He is not a known case of diabetes mellitus, hypertension, immunodeficiency, or a non-malignancy. No history of any recent drug abuse or alternative medication use. Family history was not contributory. He consumes mixed diet, consumes alcohol around 60 to 80 grams per week.
He used to travel to hometown. In his hometown, he said is in Jharkhand. Is Jharkhand endemic to? Have you done some research on?
In India, Chhattisgarh and Sikkim, there were the two studies was done.
Okay, so there have been some reports about Lymes from the northeast and the northern portions of India. Not so common. There's a report from Kerala also. So it's rare, but we have to we cannot completely negate it. Okay, so there's been a trip to his hometown 2 weeks prior to this. Okay, next.
Treatment history at MS Jodhpur initially managed as a case of Bell's palsy with tablet prednisolone.
So, was it right in managing this patient with prednisolone as Bell's palsy?
A patient with Bell's palsy will not have weakness or there was limb weakness, there was bladder dysfunction.
Probably they started prednisolone when it was just restricted to the facial weakness, and if you have facial weakness only, then and when Bell's palsy is idiopathic facial weakness. So if you have idiopathic, you don't know what the cause is, then the treatment is definitely, because it is assumed that if you reduce the edema around the facial nerve, then you can achieve a faster recovery. So in the initial stage of the illness, prednisolone must have been started on the first day or the second day, but then the patient started developing weakness, and then they gave IVIG. So were they right in giving IVIG?
So the first diagnosis possibly would have been a polyarticular neuropathy.
So probably they thought that as we are thinking right now, that this is our localization is for polyarticular neuropathy and the points favoring a bifacial weakness and a proximal and a distal involvement, which is element in presentation. The only odd thing is
the bladder dysfunction.
So in GBS, bladder dysfunction is very, 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 very rare. So whenever you have a quadriparesis and you find that the patient has a bladder dysfunction, you should be extremely alarmed about this patient, because GBS is not the first diagnosis. diagnosis. Okay, so that is the only red herring in this presentation to GBS. Okay, that the patient has a bladder dysfunction. So take it as a teaching point for the rest of your life. If you thinking that the patient is a GBS and the patient is catheterized or has a bladder dysfunction, again check daily, hourly to development of new signs. So Parvinder, go ahead, summarize.
31-year-old male with no known comorbidities presented with acute onset bilateral lower motor neuron facial weakness, flaccid quadriparesis with sensory ataxia and bladder retention with preserved sensations.
Go ahead.
Forte diagnosis: functional bifacial lower motor neuron weakness, flaccid quadriparesis, sensory ataxia with urinary retention, physiologically lower motor neuron lesion, anatomically polyradiculoneuropathy or myeloradiculopathy. Etiology can be demyelinating chronic infections, autoimmune, porphyria, granulomatous conditions, toxins, and paraneoplastic.
Yeah, just go back. After all these etiological conditions, which one would you still keep on high on the card?
Demyelinating and porphyria and acute infection.
Demyelinating as in GBS.
GPS.
So the red herring that we just discussed in the form of bladder dysfunction and chronic infection. Which chronic infection?
Lyme's and HIV.
Okay, but he didn't have HIV is a possibility. Lyme is very rare. So Lyme, so you can theoretically keep, but it's not should not be the first possibility. Porphyria we discussed. The patient has features. Whenever you have GBS and you are planning to give the patient IVIG, there are two things you should always check. And what are they, Prashant?
Albumin level, calcium,
No.
potassium.
Yeah, Major Akash.
To rule out hypokalemia.
Hypokalemia. So for all you know, this could be hypokalemic periodic paralysis. Okay, so whenever you find a flaccid quadriparesis and you are about to pump in 3 lakhs of medicine in the form of IVIG, always check potassium. If the potassium is low, think of a hypokalemic periodic. It happens. We had 6-7 cases of hypokalemic periodic paralysis coming last year. So that is a possible. Which is the second thing you should do? Suspect. Porphyria. Remember, porphyria can very well mimic a GBS. So you always think of porphyria as a possibility. So porphyria is definitely. And paraneoplastic, less likely a young individual serving guy. How old is he? 27?
31.
31. So now, granulomatous conditions like which granulomatous condition, Parvinder?
Sarcoidosis.
Sarcoid. And why did you think of sarcoid?
Bifacial involvement.
Bifacial involvement. Remember? So what are the differentials of bifacial involvement?
Among infective and non-infective etiologies, among infective, it can be bacterial or viral. In bacterial, it can be bacterial and others includes mild Lyme's disease, HIV, tuberculosis, leprosy, and even brainstem encephalitis, and even post-viral syndromes like GBS. And in non-infective conditions like sarcoidosis, other autoimmune conditions like SLE, rheumatoid arthritis, and
so a bifacial element, bifacial policy is a very important finding because your differentials become very limited. So they are either viral infections or like the common ones being HIV. It can be leprosy also from the bacteria. It can rarely be Lyme. In the West, they would talk about Lyme. In India, we don't talk about Lyme as much, but Lyme is also a possibility. Then GBS, CIDP, sarcoid. These are other non-infectious or parainfectious possibilities that you should consider in a bifacial low motor neuron weakness. Okay.
in general physical examination, he presented to command hospital on 13th of November. He was conscious oriented, height of 170 centimeter, weight of 68 kg, pulse 80 per minute, regular, normal rhythm, volume and character, BP of 126/72 millimeter of mercury, right arm supine with no postural fall, respiratory rate of 14 breaths per minute, abdominal thoracic, and normal saturation in room air, and single breath count of 45 and breath holding time of 25 seconds.
So the single breath count is important because you want, Abhishek.
If the single breath count and breath holding time are decreased, it's an indication that patient is going into a phase of respiratory failure because of the diaphragmatic involvement.
Yes. So just like neck weakness, because diaphragm in muscle is supplied with the same myotomes. The C3, C4, C5 keeps the diaphragm alive. Similarly, the neck muscles are also similar myotomes. So when they become weak, you find that the single breath count is progressively reducing. So you maintain a chart whenever you're suspecting polyradical neuropathy like GBS, and when the single breath count, that is the count you can make in a single breath, goes below 20, then you should be alert to a ventilator, possibility of a ventilator. And what is the importance of blood pressure in this patient?
So in case of AIDP, they can have autonomic dysfunction.
So a GBS patient can have wide autonomic dysfunctions causing severe hypotension or severe hypertension, can also cause severe bradycardia and severe tachycardia, almost sometimes even leading to arrest. And one of the causes of mortality in a GBS patient is this autonomic storm, autonomic dysfunction. Okay.
On examination,
Any dermatology present? Anyone from dermatology? Okay. Anyone from pediatrics? Any skin rash you would typically be looking for in this patient?
Sir, since we are suspecting infective causes also, sir, so we should be looking for any erythema multiforme kind of a rash.
Okay. Any other rash?
From that, any viral infection related rashes we can see, sir.
Okay. So since HIV is a possibility, so all the cutaneous manifestation of HIV and tuberculosis is less likely, but because that is an infection that can sometimes cause arachnoiditis, so you should consider that also, all the cutaneous manifestation. Any other skin rash? Autoimmune diseases like?
It was SLE or
Yeah, so they can some vasculitis. The typical presentation is they can cause neuropathy, but that neuropathy is generally painful and asymmetric. So not like this, but definitely you should look for those causes. Can something more important in India? You should look for a hypoaesthetic rash, because in India you should never be able to rule out Hansen's. Hansen's can mimic anything, almost anything. I've seen CIDP being a presentation of CIDP arising out of Hansen's. Okay, so that also Hansen's you cannot rule out. Any other infectious skin rash, like he's talking about Lyme. So what is the rash in Lyme?
it is erythema multiforme.
Not
Migraine.
So it's a rash which is erythematous, and then there is central clearing later. And this rash, the periphery keeps on expanding. Sometimes axilla, groin, those regions. And usually seen in white skin people, not so common in Indians and dark skin people.
nervous system examination, high mental functions are normal. His speech was he was having flaccid dysarthria, and among cranial nerve examination there was bilateral facial weakness element.
So this dysarthria was primarily because he had facial weakness.
Facial weakness.
So what are the syllables that are affected in facial weakness? What kind of dysarthria would that be?
Labials like
Labials. Those are the words that, or the consonants that come out of opposing lips, like papa. Or all the, if you go back to your Devanagari script, that is Hindi and all the Indian languages, you will find that these labials are clubbed together, like papa, pa, ma. All these words that start with these consonants, the patient will not be able to say. Instead of saying papa, they would say papa, because he's not able to oppose the lips, and that is the cause of slurring in this patient. And bifacial weakness, do you have a video of bifacial?
yes, sir.
What is happening here? He's trying to close his eyes, and can you play it again? See, the eyes are rolling upwards. This is called a Bell's phenomenon. It is a normal condition. If this rolling upward was not there, then what would you consider? Anyone?